Hey everyone, my name's Bonnie. I'm an educator in the medical ICU, and today we're going to talk a little bit about the intubation process. So, some of you may be relatively familiar with the intubation process. Some of you may have never seen an intubation before, and so we're going to kind of start at the beginning, and we'll look a little bit at kind of the basics of an endotracheal intubation. We're going to review the intubation checklist and review some of the pharmacokinetics, the drugs that we give for rapid sequence intubation, and the steps involved in rapid sequence intubation. All right, so before we get started, I'm going to hide this thumbnail over here on the right. And
Okay, so why would somebody need an endotracheal intubation? And really, when I'm assessing the need of whether or not somebody needs to be intubated, I'm looking at, what benefits is being put on a mechanical ventilator going to offer this patient? And, what can this patient not do on their own? And when I look at somebody needing to be on a mechanical ventilator, typically I'm going to be able to put this into three primary categories. One, they are hypoxic. They need help with their oxygenation. The second category is hypercarbia or hypercapnia. They're having a ventilation problem. And this is a ventilation problem that we really can't control on BiPAP, or, it's too severe to be really alleviated by BiPAP. So 1 and 2 are kind of the big indications. And for more information on oxygenation and ventilation, I'm going to encourage you to see the respiratory lecture that I've put out. So 1, oxygenation. 2, ventilation, and the third primary one is going to be airway protection. So loss of my airway reflexes, encephalopathy, kind of an altered mental state, where we're really concerned that this is an individual who, in the event that they would need to do so, they are unable to protect their airway. And I added one other category in here, although this really can be oftentimes placed in the hypoxemia, hypocarbia sort of scenario, which is really just an overall hemodynamic instability that's occurring. So perhaps I don't have all of the other information, but somebody who's extremely unstable, I'm very worried about, I may go ahead and intubate them in order to make sure that we don't get too hypoxic or too hypercapnic. Okay. So one of the things that I always like to point out, especially when I'm talking to folks who have only worked in the ICU, is I remember when I made the transition from acute care to critical care, when I saw intubation for the first time, I was, I think, probably relatively traumatized by just observing an intubation occurring for the first time. I was extremely convinced that, the person intubating was going to rip out the front of this individual's trachea. And as I learned later, this was a relatively routine intubation. There wasn't anything unusual about it. It went relatively smoothly. The patient was able to recover quite well. So I always like to point out that, as time went on, for me, intubation became almost part of my daily routine. It became something that I participated in all the time. I became a lot less fearful of it. And as time continued to go on, I really started to lose that fear that a patient was going to need to be intubated and what that meant. And because it became so casual for me, I forgot that really intubating people truly does carry quite a bit of risk, especially when we put that patient in an ICU. So I wanted to include just a couple statistics about the risks that intubation carries. And I typically when I'm teaching this to individuals who are starting in pulmonary critical care in the medical ICU, I like to include the information that the majority of the patients that we're treating here are going to be patients who are already on the sicker side. Their acuity is already going to be a little bit higher. So some of these statistics probably be even a little bit higher for what we see in the clinical setting versus this is sort of an overall statistics that I pulled from. So About 40% of our patients will experience some sort of post-intubation hypotension. And that statistic doesn't surprise me at all. What does surprise me is that post-intubation hypotension is associated with with nearly doubling their mortality risk. That was the part of the statistic that really shocked me because, in my mind, post-intubation hypotension is very normal, very regular, happens about half the time. What I didn't know is that 40% that does occur to, their mortality risk has just almost doubled. So the next one, profound hypoxemia. So this happens in about 40% of patients who are intubated. And that statistic didn't surprise me either. You see this a lot in patients that are getting intubated where their oxygenation, really very acutely. It's very short term, but does sort of suffer, and the patients become relatively hypoxic, especially if it's a difficult airway or, you know, um, uh, perhaps intubation has been delayed for any reason, and they really just don't have a lot of oxygen reserve available for the tissues and the organs in the body. Once again, the part that surprised me was that when a patient is profoundly hypoxic during an intubation, this statistic alone associates them with four times the risk of cardiac arrest during the intubation. So that was the part that really sort of startled me. 4 times the risk of cardiac arrest in these folks. The next one we're going to look at is an esophageal intubation. Now, you'll notice this is roughly around 5%. And to be honest with you, this is something that I really haven't seen very often. I've seen a handful of times. And the majority of the time, if I'm treating somebody who has had an esophageal intubation, this is an intubation that oftentimes is coming from an outside facility where I hear they were esophageally intubated, or when I used to work in the emergency department, somebody who was esophageally intubated in the field, or intubated, in a moving vehicle with EMS. And, we really don't, at least in my clinical practice, I really haven't seen too many esophageal intubations occur, in the ICU setting, which is good because an esophageal intubation, you'll notice, not that common, but is associated with 7 times the risk of cardiac arrest during an intubation. So ideally, for those of you who are more unfamiliar with intubation, what we're looking for is for this tube to go in. It's an endotracheal intubation, and the trachea and esophagus are very close to each other. The trachea going to the lungs, the esophagus going to the stomach, and the esophagus is a much larger structure, so it is quite easy to do an esophageal intubation. But thankfully, it only happens about 5% of the time, and that's very good that it's so rare because it obviously has a very high risk for procedural cardiac arrest. And then standard, out of all intubations that are going to occur in the ICU, you're looking at 2 to 3% resulting in some sort of cardiac arrest event, just at a baseline. Some other risks that may occur during intubation is, of course, aspiration, a patient developing cerebrocardia, traumatizing the airway in some sort of fashion with the endotracheal tube or the blade. And really, obviously, these are, much less common than some of the other risks that we've looked at. But it is, like I said, it is very common for me to see patients get hypotensive. It is very common for patients to get hypoxemic. And so a lot of the things that we do during intubation are to sort of help mitigate those from occurring so that we can really maintain a lower risk of mortality and a lower risk of cardiac arrest during this procedure. So let's go on and look at, what is the goal? And I mentioned this a little bit. And this may sound really simple, but the overall goal is if we can avoid an endotracheal intubation, we should. And, that's something that I think everybody gets to take a little bit of responsibility in, and especially in a nursing standpoint, is all of the respiratory maneuvers, recruitment maneuvers, incentive spirometers, flutter valves, sitting up in an upright position, and really allowing that patient to deep breathe when they are not intubated is a really important part of pulmonary care. So if we can avoid it, let's do that. If we have to intubate somebody, the goal is to get it done quickly and to get it done safely so that we can really avoid a lot of those risk factors that we talked about. So when we talk about endotracheal intubation, oftentimes you will hear people throw around the term RSI. And so I wanted to spend a little bit of time actually discussing what is RSI, because in the two, depending on where your physician is trained, or the work environment that you're in, there are two primary types of rapid sequence intubation, or RSI, and they look a little bit different. And it can be, if the rest of the team is not as familiar with the type of RSI that the physician wants to perform, things can just feel a little bit more stressed than they need to feel in an already relatively stressful environment. So let's look at these two different types. We've got classic RSI and modified RSI. Okay, so I'm going to bring up the definitions of both of these. So classic RSI we'll talk about first. Classic RSI, essentially, I'm not going to read this to you, but essentially what classic RSI means is that we are pre-oxygenating ahead of time, and then when we administer our RSI medications, which includes a quick onset of sedative or anesthetic, and immediately followed by a neuromuscular blocking agent or paralytic. During that time where the medicines have been pushed and we're allowing them the opportunity to start to work, the patient in this scenario is not being bagged. Okay, so we've pre-oxygenated, maybe put them on a non-rebreather, or had some flow by oxygen if they're still spontaneously breathing on their own. And when the drugs have been given, we do not continue to bag them. Okay. From a nursing standpoint, what this means for medication administration is that you administer the sedative, the anesthetic, and then immediately follow that with the paralytic, and then a 20 cc saline flush. So this is really important. A lot of people have concern about, well, did I give this sedative enough time to kick in before paralyzing a patient? And I'll talk to you guys in just a little bit when we look at these medications of why that is actually not a concern. So a sedative followed by a paralytic, followed by 20 cc's of a saline flush. Okay, so that's classic rapid sequence intubation, which is a little bit different than modified rapid sequence intubation. So this is very, very similar. However, there is a small deviation, and the deviation is that until the physician is ready to put the blade in and place the endotracheal tube, we're going to continue to give this patient oxygenation and ventilation support, meaning that we are going to continue to bag them with a bag valve mask. So why would we want to do that? Most relatively healthy people can tolerate classic RSI. And all of us probably listening to this presentation are able to hold our breath for somewhere close, 30 seconds or a minute, and not have a significant and dangerous decrease in our oxygenation status. Modified RSI is for those patients who really cannot tolerate not getting oxygen and ventilation support for that short period of time. So this is typically an oxygenation problem. It may be an acidosis problem, but most of the time, these are your patients who are already very, very sick. These are your patients who perhaps have chronic lung disease, perhaps, already have a very, very low oxygen saturation to begin with. And so we sort of say, I don't think they're going to tolerate not being bagged for the next 30 seconds, a minute, whatever that time frame happens to be. And then as a result of that, we're going to continue to bag them until I am actually ready to place the blade into the patient and place the endotracheal tube. So why not do that for everybody, right? That sounds, giving more oxygenation and more ventilation support sounds like a great answer for everybody. But there are some downsides to modified RSI. And one of them is that when we bag somebody, when we do a BBM and are bagging them at their mouth, some of that air is going to go into the stomach. Okay, so some of that air is going to go into the trachea and into the lungs, and some of that air is going to go into the esophagus and into the stomach. So when we do modified RSI, oftentimes we place these patients at a much higher risk for regurgitation and aspiration. And for individuals that aspirate during intubation, it can be pretty severe, have some severe consequences. Of course, if it makes it incredibly difficult to actually visualize the airway at that point, if they aspirate a significant amount. So this is really, the most part, reserved for patients that simply won't tolerate classic RSI. And oftentimes, somebody may start with the idea of, I'm going to do classic RSI and we're not going to bag. And if the patient begins to decompensate and begins to desaturate from an oxygen standpoint, may transition to modified RSI in order to provide a little bit more of a barrier. But for the most part, this is definitely something that, I try to assess prior to initiating an intubation procedure. Okay, so we're going to talk a little bit about pharmacokinetics. And when we talk about pharmacokinetics, we're looking at 3 categories of drugs. I'm going to look at, we're going to talk about pre-induction drugs, induction drugs, and paralytics. All right, so when we talk about pre-induction and induction, what that induction is an induction into an anesthetized state, okay? So most commonly, depending on where you work, your physician colleagues may have a preference for, one drug combination over another. You may use multiple different types of medicines based off of, the patients that they're treating. So we're going to take a look at some of the most common drugs that are used, and you may use other ones, and let's see, let me bring up, this is kind of a list of common drugs that are used, and we're going to look at these in a little bit more detail. But what I have here is fentanyl, midazolam, etomidate, ketamine, propofol, rocuronium, succinylcholine, and cisatracurium. Okay, so those are going to be some of the most common drugs that we use. And really, when we put these into categories, our pre-induction drugs may be these things up top, the first 2, fentanyl and midazolam. Midazolam at dosages can certainly also prove to be an induction drug. The etomidate, ketamine, and propofol fall into that induction of anesthesia category, and sedatives. And then the bottom 3, rocuronium, succinylcholine, and cisatracurium, are all neuromuscular blocking agents that are responsible for paralyzing the patient. Sometimes people ask me, why do we paralyze folks when we intubate them? And the primary response behind that is, we are really going to be passing an endotracheal tube down past a couple reflexes and part of the upper airway. And the idea is that what I don't want to happen is for the airway to spasm around the endotracheal tube as I'm trying to pass it. And so if we can eliminate, the gag reflex and the cough reflex, and maybe we can sort of eliminate some of the complications that occur with the intubation process. Okay, so this is probably one of the most important slides that we're going to talk about today. So I'll share with you guys sort of preference for personal preference for rapid sequence intubation, although you may see multiple varieties of this in clinical practice. I am a big big proponent of giving a pre-induction drug, and I don't necessarily have a preference over fentanyl or midazolam, but something to sort of calm the patient down ahead of time. I tend to lean a little bit more towards midazolam simply because it has a little bit of a longer duration. And we can give it to the patients um, much earlier and give it some time to sort of set it. And if we know that intubation is going to occur and it's a planned sort of ordeal. However, the beauty of fentanyl right here is this very, very fast onset. So if I need to quickly sort of calm somebody down, this is a really, really great alternative. Looking into the induction drugs, so we've talked a little bit about fentanyl, midazolam. So these are both medicines that an RN can push, eh, without, you just need an order. When we talk about anesthetics and induction agents like ketamine, propofol, and etomidate, these are all considered anesthetics, especially at the doses that we would be giving them during rapid sequence intubation. So normally, a registered nurse cannot, in the state of in most states, can't push induction agents. Typically, this is going to be reserved for an anesthesia provider or um, CRNA or an anesthesiologist or, physicians that may have additional credentialing for things. During rapid sequence intubation, there are several other fields that have the ability to push rapid sequence intubation drugs. And certain nurses who have been through additional training can oftentimes also push these induction agents under the premise of rapid sequence intubation. And that is the only time that they can push these induction type agents usually. So we're going to talk about each of these in a little bit more detail. Now, the RSI drug cocktail that tend to use in the area where currently am is an etomidate and rocuronium. So I'm going to go into a little bit more detail with that particular combination, but I want to talk about all of them because we do use almost all of these medicines. So starting off with ketamine. Ketamine is sort of made a comeback over the last several years. This may be a medicine that your facility or your department uses very frequently, or it may be a medicine that you've only heard about from the streets. The great thing about ketamine is that it does have a quick onset, a 30-second onset, and it has a decent duration, a 5 to 15-minute duration. Now, there are some downsides to using ketamine. But one of the significant benefits that we see, and one of the primary reasons that someone may select to use ketamine during an intubation as opposed to propofol or etomidate, is that you'll notice off to the right hand side, the side effect is that ketamine actually oftentimes causes your blood pressure to go up. Okay, so most of the patients who are hemodynamically unstable, are hypotensive, needing to be intubated, very oftentimes may be hypotensive with a very low blood pressure. Both propofol and etomidate can have an effect on blood pressure that causes it to fall, and ketamine tends to have the opposite effect. It tends to have to kind of help the blood pressure go up. Now it is, oops, sorry about that. So that is oftentimes one of the primary reasons that somebody may use ketamine, and there are other reasons, but anytime that someone's going to be intubated who's hypotensive and dangerously hypotensive, this is definitely something that I might suggest to the individual who is intubating. The next drug that we're going to look at is propofol. So propofol, once again, has a very quick onset, a relatively short duration. Now, propofol in healthy individuals is a perfectly acceptable drug, or patients who are incredibly hypertensive, perfectly acceptable drug. We really don't use it in patients that are already in the ICU, especially in medical patients who oftentimes are already hypotensive, because it can have a really profound effect on someone's blood pressure and cause it to fall quite a bit. So really don't see propofol used as much for patients that are already in critical care environments. Do see it, especially if you're working with anesthesiologists who, you're working in operating rooms and things like that. They may use propofol a little bit more than, say, a pulmonary critical care physician who's used to dealing with patients in various stages of shock. The next drug we're going to look at is a drug called etomidate. So etomidate is oftentimes the drug of choice where I work, and it has kind of a quick onset, this 30 to 60-second onset, and a pretty short duration, so around 5 minutes. So definitely the shortest of the durations, and tends to have less of an effect on blood pressure than propofol, but it may still cause it to drop a little bit. So far we've looked at kind of the pre-induction drugs and the induction drugs. So sort of those calming, sedation type drugs, and then true anesthetics and sedatives. The last category here is our neuromuscular blocking agents. These are going to be our paralytics. So succinylcholine is a very commonly used paralytic for intubation, especially in emergency departments and operating rooms, depending on how long the procedures are. And the thing about succinylcholine here, it does have a very quick onset. So sometimes in patients, who are very quickly deteriorating, people choose to select succinylcholine because the onset is much faster. And with a faster onset, you're going to also have a little bit of a shorter duration. Now, we do not use succinylcholine in the patient population that I work with. It does have a risk of malignant hyperthermia. It's not a common occurrence in patients that receive this, but it definitely is a very, very serious side effect that can occur. And the other side effect that succinylcholine has that plays a little bit more dangerous for where we are is it tends to have an effect on the electrolyte channels on a cellular level, and what it can cause is a relatively rapid increase in potassium and serum potassium levels, which the majority of patients that we're treating, in my particular department, it already maybe have some chronic kidney disease, or already having electrolyte disturbances, or have underlying cardiovascular disease that really, can't tolerate a rapid influx of potassium like that. So we very infrequently choose to use succinylcholine, but it is an extremely commonly used drug in other areas of the hospital that I'm in. The neuromuscular blocking agent that I use the most of is rocuronium. So this is another paralytic. Now, what you'll notice about rocuronium versus succinylcholine is rocuronium does have a little bit of a longer onset and a much longer duration to it. Okay, so the example that I like to use when I teach about intubation is, the common combination that we tend to prefer is an etomidate and rocuronium combination. So going back to why, in classic RSI and modified RSI and any type of rapid sequence intubation, I talked about how you can give the sedative and then turn around and give the paralytic immediately behind it, and then flush with 20 cc's of normal saline. And this is why. So etomidate has a 30 to 60-second onset. So if I give my etomidate right off the bat, then I turn around and I give my rocuronium, which has a 1 to 2 minute onset, that etomidate is really kicking in by the time that rocuronium has a chance to kick in. Now, one of the biggest points that I like to drive home in this combination is that, once again, etomidate's duration is only about 5 minutes. Rocuronium's duration is about 45 to 70 minutes. So when I'm dealing with a paralytic, I always go on the high side of the duration. Now, in some patients, depending on the dose of rocuronium that you gave, the duration may be less than that. In others, it may be more than that. But I always like to go on the high side because what I absolutely do not want to happen is to have a patient lying there, not sedated, and paralyzed. really struggle to imagine a scenario much worse to be in than that. And so, one of the main concerns about this is that my sedative, my anesthetic, is going to wear off in about 5 minutes, but my patient is still going to be paralyzed upwards of an hour. So in that first hour, we're pretty large proponents of light sedation on the ventilator. However, in that first hour after intubation, it is crucially important that these patients are, very heavily sedated, and it's very crucially important that, after that 5 minute window, if the patient's receiving other medicines like fentanyl and midazolam, that 5 minute window may be extended some, but that I start to become aware, especially if you're looking at this from a nursing standpoint, is that please do not let that physician, don't let that provider leave the room without giving you some sort of sedation plan. Because oftentimes what I see is people walking out and saying, oh yeah, I'll put some orders in. Well, really 5 minutes isn't very long. Probably by the time they're finished intubating, and kind of getting everything sort of taken off and doffed, that etomidate starting to wear off. So this is why, for me, the course of action that I tend to prefer the most is going to be some midazolam on the front end, because it's got that long duration, it's got a longer onset while we're getting everything set up, if the patient will tolerate it, the etomidate and rocuronium. And then after kind of that 5-ish minutes, if the patient's blood pressure will tolerate it, starting to give some fentanyl, getting some fentanyl on board, because it does have that very quick onset. So I really lower the risk of that patient being paralyzed and not sedated, which is something that I definitely want to avoid, at any point in time, not just during intubation. So one of the things that's really helpful on this particular graph is to have some sort of idea of what the onset of those medicines is and what the duration of those medicines is, so that we can really avoid that scenario. The last paralytic that's listed there is cisatracurium. We really don't use cisatracurium in an IV push for intubation, but it is a very commonly used paralytic, especially if we're going to continue to paralyze somebody for ventilator synchrony or a procedure, or anything like that. Okay, so I know that's kind of a lot of information about drugs, and like I said, there may be other drugs that you guys use more routinely. This is sort of the first line of medicines that I see being used for rapid sequence intubation. And very similarly to induction agents, in most places, a registered nurse is not supposed to be pushing paralytics at all, ever, unless the patient is already intubated and on a mechanical ventilator. They already have a protected airway in place. There will be some specially trained nurses who are able to push paralyzing agents during rapid sequence intubation, and those nurses have had additional training and been validated by their credentialing boards and kind of gone through that process. So the next thing I want to look at, and this is just a very brief overview and intubation checklist. This is something that is really expected for, in the department I'm in, our fellows predominantly intubate. And this is something that the expectation for the fellow and the respiratory therapist at the bedside to run through this checklist as things are being intubated. And there are a couple things that I want to pull out for responsibilities from the RN standpoint. Okay. Now, of course, if you're in a critical care environment, probably your room is already set up with working suction, and you already have a yonker, and you may already have a VAG valve mask. But a couple of things that may look a little bit different is do I have working access? And that sounds maybe a little bit basic, but there are few things more disturbing than going to intubate somebody and realizing that none of the drugs that, you can't put a blade in because the patient is still awake and not paralyzed. And so, checking, do I have good access before I start to give these medicines is a really crucial part of this process. The next responsibilities from a nursing standpoint may be to do I have the right people in the room with me? Do I have a respiratory therapist? Do I have a physician who can intubate? Not all physicians can intubate. So do I have somebody in this room who can intubate? And do I have a nurse who, if I'm unfamiliar with intubation or I'm not comfortable with intubation, or perhaps I'm not a nurse who's been specially trained to push RSI medications, and do I have somebody in the room who can do that? Um, is a really important part of the process as well. Other things that may be a nurse's responsibility is to help get the patient in position. Now, oftentimes the physician sort of leads this based off of their preference as to how they, like the patient to be positioned. And we'll look a little bit at kind of the patient's neck structure. And respiratory therapy oftentimes will sort of help them get that positioning correct. But are they pulled up in the bed appropriately? Have we moved the bed away from the back of the monitor so the physician has a place to stand? And the rest of the stuff in this center section is really going to be things that respiratory therapy is going to pretty much be running through. And our respiratory therapist and fellows that I work with do call this checklist out loud every single time they intubate. And they don't carry the checklist in there with them, mostly because they pretty much all have it memorized, but you will hear them saying, I have a Yonker with working suction. I have a bag valve mask. Do I have a PEEP valve? Yes, I have a PEEP valve. We have the patient in the right position, evaluation of difficult airway, and really kind of going down this list. And it's very helpful for anybody in the room because it really gives you an idea of, what are the thought processes for the other people that are going into this procedure with me. Other parts for a registered nurse that are very helpful and important during intubation is, the physician who's intubating has their back to the monitor, which means, and is really focused pretty narrowly down on the patient's airway itself, as is the respiratory therapist who's responsible for, equipment and getting things like that set up and available. So the nurse in the room is really vital to monitoring the actual patient at this point. If the nurse in the room gets tied up doing something else, this role can be filled by anybody, but it is helpful to have somebody at the foot of the bed who's looking at the monitor and really updating the rest of the team as to what's happening. For example, if everything is going fine and the patient's oxygen saturations are staying in the mid-90s, oftentimes if I happen to be in that role, you may hear me saying things like, the patient's oxygen saturation is 96%, you're at 94% and holding, heart rate is stable, blood pressure is stable. Every couple of seconds, just to really reassure the rest of the team that doesn't have that knowledge that everything is going fine, to not panic, to stay calm. And I have had people tell me before, to be quiet, or to update them less often because they've found it irritating and difficult, disruptive to their focus. But for the most part, people are very appreciative of having too much information over not having enough information. And, on the flip side of that is when things are not going well, I'm certainly not going to scream at them, their oxygen's 70%, but in a calm tone of, your oxygen is 92%, if you're at 86%, your heart rate is dropping, it is now in the 60s, your oxygen level is at 81%, your heart rate is 52, and just really feeding them information so that they know, okay, I need to be thinking of an alternative plan because, this patient is not tolerating the procedure at this point. So the options there are, can I get the tube in quickly and be done? Or do we need to stop and bag and sort of reevaluate, what would be best for the patient in this scenario? Other things that sort of fall under the nurse's jurisdiction during any procedure, of course, would be, will I need IV fluids? Will this person need vasopressors? Things like that. Just things to be thinking about. If I see their blood pressure starting to fall and this person is a candidate for, a fluid bolus, do I have that easily accessible? Because what I don't want to do, or do I have somebody who can go and get me that if it's something that I need? What I don't want to do is leave the respiratory therapist and the physician in the room with no one to watch the monitor while they're trying to intubate to go get a bag of fluids. That's typically not a good scenario for anybody to be in. So, of course, before we intubate, we definitely want respiratory therapy in the room. They are our best friends. I, for many years, relied very heavily on respiratory therapy to help me figure out what was going on with a lot of patients. They are the experts. And who else needs to be at the bedside? If I am a nurse and I've never been in intubation, I would like somebody who's a little bit more experienced in this scenario. Am I prepared to pre-oxygenate? Do I have IV access? Do I have the medications? And the physician will usually tell you exactly what they want. If you are in a department where you happen to have a CMAC or the area I work in has a difficult airway cart that has all of the equipment we would need in a difficult airway. Do I have access to those things? If I, if the physician is unable to intubate, what's the next step? Do I call anesthesia? What's their phone number? Mostly because I don't like to be in an emergency scrounging around for things. I like to be as prepared as I can be. And I may not need any of those things. It may go very well, but I'd much rather have it and not need it than vice versa. Okay, so the steps to intubation, this is really more so for the physicians, but I think as an RN, it's really helpful to sort of know what their process is. And so essentially, what they are thinking typically at this point is, is this person going to be a difficult airway? Step one. Step two, while we're pre-oxygenating, starting to really plan sort of what the procedure is going to look like. Getting them in position. Step three, running the checklist. The expectation in the area that I work is that is done out loud. Step five, following the plan that you've really created in step 2. 6, rechecking vitals, patient appearance, making sure that they're ventilating within the parameters that you expect. And step 7, sort of getting the ventilator set up with respiratory therapy and really communicating the plan back to the rest of the team. And you'll see in big red capital letters, don't let them leave without a sedation plan. Even if the patient is not going to be sedated for most of their intubation, they still, if they have been given a neuromuscular blocking agent, they're still paralyzed for at least, the next little while. And so definitely something to just consider is that we really don't want them laying there paralyzed and not sedated. So a little bit of a look at intubation equipment, and I'm actually not going to really go into intubation equipment in this talk, but you'll see that these are just a few pieces of equipment that you're welcome to spend a little bit of time looking up on your own if you have interest in it. There are a couple different blades that are commonly used. We mostly use Mac blades. Where I work, I do know several anesthesiologists that really prefer the Miller blade, and there are reasons for that as well. And just some other pieces of equipment that we use. Airway assessment, I'm really going to kind of skip over some of that because it's really, the onus of the physician who is performing the procedure. But it is nice to know a question that can be easily asked. As a nurse, certainly the expectation is not that you're assessing the difficulty of the airway, but it is, if you're very nervous about the intubation, a question that you might ask is, do you expect this to be a difficult intubation? And they can, the physician can give you an answer back of, no, I don't see any reasons why it would be difficult, or, yes, I'm a little bit concerned because of, because of this, and kind of give you the reason, which sort of allows you to mentally prepare what may or may not be happening, or may or may not happen during the procedure. And this is just an example. I included this. This is pictures of the patient's neck during an intubation procedure. So oftentimes, when, especially during valve mask ventilation or during intubation, when people are assisting getting the patient in a proper position, oftentimes they tend to overdo the extension of the neck, which and just to look at the angles of where the tube has to go. So this would be somebody laying in a neutral position, and you'll see that this right here is a pretty sharp angle. That's almost a 90-degree angle right here, and then another angle down here, which makes it a little bit more difficult to makes it quite difficult to visualize the airway, visualize the vocal cords, and actually get the endotracheal tube in. And then, of course, when we lift the head, this angle here changes pretty significantly and is greatly reduced. So it's not quite as deep this way. And this is sort of where most people tend to have a little bit of a pitfall. So keep in mind here, this is where this sort of indicates the difficulty of visualization. So that's pretty steep. This helps a little bit. The extension of just cranking the neck back puts you back in a pretty difficult spot to sort of visualize. So what we're really going for is what's called the sniffing position, which is a head lift plus a little bit of extension, but you'll notice this is not nearly as extended and flexed, and you can kind of see it isn't, this angle here is a lot steeper than this angle here, and you get a really nice kind of flat angle here, a little bit more than you get just in the neutral position and in the head lift. So the sniffing position is really what we're looking for in order to visualize the vocal cords as easily as possible and intubate quickly and safely. So if you guys have any additional questions on the intubation process, please let me know. If you think of any information that you would like clarified or would be helpful to include, you're more than welcome to reach out. I can make addendums to this, or I can answer your questions on an individual basis. And thank you guys for listening. I hope this was helpful.